That is mute. That is muted.
Okay.
Shojil sir is mute. Sir, please unmute.
Yeah, Dr. Jasmine, I think it's the time to start now.
Okay, sir. Assalamu alaikum and good evening to all. I am Dr. Jasmine Akhtar Lina, Assistant Professor in Department of Dermatology of Sir Solimullah Medical College, Dhaka. Embracing Life with Vitiligo, the theme for 11th World Vitiligo Day, which was celebrated in 25th June of this month. Each year, World Vitiligo Day has become a bigger and bigger event. Now with vitiligo sufferers, their families, caregivers, and physicians making an effort to talk and create awareness about the disease, empowering the patients, raise money for research, and educate doctors on how to take best care of patients with vitiligo. World Vitiligo Day was first celebrated in 2011 in the memory of late pop king Michael Jackson, who suffered from vitiligo and died on 25th June of 2009. As a part of celebration of World Vitiligo Day 2021, our today's webinar is on how to approach a case of vitiligo, jointly organized by Association of Cutaneous Surgeons of Bangladesh and Psychodermatology Association of India. Today we have 4 speakers who will talk about the overall approach to vitiligo patients and also reflect our commitment to the vitiligo community. It is my privilege to introduce them one by one. First, I would like to introduce the President of Psychodermatology Association of India, Professor Dr. Abdul Latif. He is the additional professor in Department of Dermatology and Venereology of Calicut Government Medical College, India. He is also the fellow of International Medical Science Academy and member of European Society for Dermatology and Psychiatry. He is the chief editor of Handbook of Psychodermatology and has published many articles in different national and international journals. His area of interest is psychodermatology and cosmetic dermatology. Next, we have Professor Dr. M. Sindhil Kumaran. He is the additional professor in Department of Dermatology, PGIMER, Chandigarh, India. He has 185 publications and many presentations. He received Ellen Sinha Award and IJDVL Best Research Paper Award in 2020. He is the chief editor of Pigment International Journal and deputy editor of IDOJ. His area of interest is pigmentary disorder and urticaria. Our another speaker is Dr. Mahbub Shaheen, the Secretary General of Association of Cutaneous Surgeons of Bangladesh. He is the senior consultant in Aurora Skin and Hair Research Institute. He is a very academic dermatologist and experienced hair transplant surgeon. His area of interest is hair loss disorder and vitiligo. And the next speaker, very dynamic, Dr. Mahmoudur Rahman, the consultant dermatologist in Lakshmipur Shodor Hospital. He got International Society for Sexual Medicine Scholarship in Hungary in 2019 and EADV Scholarship in 2020. He is selected as International Society for Sexual Medicine Young Trainees Committee member. His area of interest is clinical dermatology and venereology. This webinar session will be chaired by the Honorable President of Association of Cutaneous Surgeons of Bangladesh, Professor Dr. Mohammad Shohidullah, a very respected pioneer dermatologist and dermatosurgeon of our country. Today we have 5 expert panelists, 2 of them from India and 3 from Bangladesh. They will share their knowledge and experience regarding the diagnosis, treatment, social and psychological aspects of vitiligo patients in this subcontinent. It will be my pleasure to introduce them. First, I would like to introduce our renowned Professor of Dermatology in Bangabandhu Sheikh Mujib Medical University, Professor Lieutenant Colonel Retired Dr. M. A. Wahab. He is our inspiration and academic guide. Next, I am delighted to introduce Dr. Smita Prabhu, Associate Professor in Department of Dermatology of Kasturba Medical College, Manipal, India. Next, we have our very friendly Indian colleague, Dr. Bishurul Hafi, the consultant dermatologist in IQRAA International Hospital and Research Center, Kerala, India. He is also the Secretary General of Psychodermatology Association of India. Our next expert panelist is Dr. Tawhidul Islam Imdad. He is the Associate Professor in Jalalabad Raghib Rabia Medical College, Sylhet. Dr. Imdad is a very dynamic and academic dermatologist, and his area of interest is dermatosurgery and eczema. Our next and last panelist is Dr. Rahmatullah Siddiqui, Senior Consultant of Aurora Skin and Aesthetic Clinic. He is a very knowledgeable dermatologist having special interest in clinical dermatology. Today, as a special guest, the Associate Professor of Dermatology in Bangabandhu Sheikh Mujib Medical University, Dr. A.T.M. Asaduzzaman Sir, is also with us. I extend a warm welcome to everybody. Now, I would like to request our respected chairperson, Professor Dr. Muhammad Shahidullah Sir, to say a few words and to start the session. Sir, please.
Thank you, Dr. Lina. Good evening to everybody. I welcome my participants and my speakers from home and abroad. I welcome them. Today's subject is a very interesting one. At the eve of Vitiligo Day, although it was yesterday, the Vitiligo Day was, and we are enjoying this teaching from the Vitiligo Day. So our today's subject is very interesting, and I hope the speakers will narrate very nicely and the participants will enjoy that. So without expending any more words, I will request Dr. Lina to go forward.
Thank you, sir, for your welcome speech. Now, before going to the presentations, it would be my honor to request the President of Psychodermatology Association of India, Professor Dr. Abdul Latif, to give a short welcome speech. Sir, please. Dr. Latif, sir, please.
Yeah, very good evening to you all. This is a very happy occasion. This is the second time we are meeting together from India and Bangladesh. And especially this second program that is regarding Vitiligo Day celebration. Now, this is an important area we have selected, especially the time is very important time we have selected this program. So I congratulate the Bangladesh team for cooperating with us for arranging this program. And I welcome all the faculties and the senior members from Bangladesh and India, and all the faculties and panelists for attending this program to make this a grand success. I'm not extending my words because the time almost, I think, 15 minutes late. So we can discuss the rest in the coming sessions. Thank you very much. Thank you. Thank you.
Thank you, sir, for your warm and inspiring welcome speech. Now the presentation session. And our first speaker is Dr. Mahmudur Rahman. He will briefly point out about the basics and diagnostic approach of vitiligo.
Madam, I am visible and audible?
Yes, you are
Thank
visible
you.
and audible both.
Thank you. Basic of vitiligo. Actually, Bangladesh and India friendship webinar. I congratulate and welcome to you all in this webinar. Yesterday was World Vitiligo Day. That day was established due to the presence of vitiligo of the pop singer Michael Jackson. 'So I remember in this session. And I am Dr. Mahmoud Rahman from Bangladesh. No conflict with others. And now vitiligo, we all know that it is acquired depigmenting disorder. Pigment cell, that is melanocytes, are lost. Well-defined milky white patches of skin, cosmetically very disabling. It's 0.5 to 1% of population. All races may affect, and more common in India, up to 8.8% in a study. Pigment loss begins before the age of 20. About 80% start before the age of 30 years. 20% of other family members also have vitiligo. Males and females are equally affected. Loss or destruction of melanocyte, which produce melanin. Melanin determines the color of skin, hair, and eyes. Skin color becomes progressively lighter. So the cause is idiopathic, main cause. Neurogenic factor, autoimmunity, and otocytal toxicity may reason. The association, autoimmune thyroid disease, type 1 diabetes mellitus, pernicious anemia, and additional disease, we all know about it. Distribution, it may involve in anywhere of the body, but may mainly mouth and eye, fingers and wrist, armpit, groin, genitals, and inside mouth. Types, we all know it is two types, non-segmental vitiligo and segmental vitiligo. Non-segmental vitiligo, it's divided into focal vitiligo, acrofacial, mucosal vitiligo, generalized vitiligo, and universal vitiligo. And segmental vitiligo, which is less common, more common in children, usually starts in earlier age. Segmental vitiligo affected skin are associated with dorsal roots from the spinal cord, more stable, associated autoimmune diseases. Triggers, some trigger factor like stressful events, skin damage, like severe sunburn, inflammatory skin condition, exposure to certain chemicals, and inhalational steroid injection. Now, symptom of vitiligo: patchy loss of skin color, premature whitening or graying of hair, loss of color in mucous membrane. We all know about it. Now, differential diagnosis, some differential diagnosis: chemical leukoderma, pityriasis alba, tinea versicolor, post-inflammatory hypopigmentation, tuberculoid leprosy, halonibus albinism, paludism, idiopathic gouted hypomelanosis, progressive macular hypomelanosis. First, chemical leukoderma, which is acquired form of cutaneous pigment loss, exposure to a variety of chemical, selective melanocytotoxicity. Numerous acquired confetti or P-shaped macule is clinically characteristic. Spontaneous repigmentation has been reported when the causative agent is avoided. Now, pityriasis alba is commonly seen in children and young adult. Dry, fine-scaled, pale patches on the face. It is still limiting condition, and it has 3 stages: it is raised and red, raised and pale, and then smooth, flat, pale patches. This is due to reduced activity of melanocytes, fewer and smaller melanosomes. Now, tinea versicolor, we all know, patches of skin discoloration, usually on the back, chest, neck, and upper arm, may appear lighter or darker than usual, mild itching, scaling. Now, post-inflammatory hypopigmentation can occur, skin injury, skin disorder, some medication like strong corticosteroid and benzoyl peroxide. Tuberculosis leprosy, you all know, solitary skin lesion, asymmetrically distributed, well demarcated edges, early and marked nerve damage. Halonibus, usually seen in healthy children or young adults, currently classified as autoimmune in origin, triggered by sunburn or local trauma. It has 4 stages. Stage 1, rim of pale skin surrounded a mole. Stage 2, mole may become pinker or less pigmented and fades away. Stage 3, circular or oval area of depigmentation persists. Stage 4, affected skin gradually returns to its normal color. Now, albinism, it is congenital condition, complete or partial absence of pigment in the skin, hair, and eyes, associated with vision defect, more susceptible to sunburn and skin cancers. Paludism, absence of melanocyte in certain areas of skin and hair. Approximately 90% of affected individuals have a white section of hair near their front hairline. Idiopathic guarded hypomelanosis, which is smooth, pale, hyperpigmented to depigmented macule, 2 to 5 millimeter ranges, most commonly on the sun-exposed aspect of forearm, chin, and V area of chest. Usually multiple and asymptomatic familial cases are common. You all know about it. And another condition, progressive macular hypomelanosis, numerous hyperpigmented macules and patches affected primarily lumbar region and abdomen, ill-defined numera and symmetrical without scale, asymptomatic, without history of preceding infection, inflammation, and injury. Now, investigation mainly wood slump examination and dermoscopy, and skin biopsy may help. And sometimes wood slump examination will know dermoscopy. Latest technology, white structureless area, that is black stars, perifollicular pigmentation, that is yellow arrow, and reticular pigmentation, that is red arrow, and perilesional hyperpigmentation, red stars. And another, white structureless area, red star, and perifollicular pigmentation, red arrow, and another, white structureless black stars, and perilesional pigmentation, yellow arrow, and satellite lesion, black arrow. So investigation other complete blood count, random blood sugar, thyroid function test, B12 level, and autoantibody skin managed. Skin biopsy for histopathology, absence of melanocyte in basal layer of the epidermis. Clinical photograph is useful to document the extent of vitiligo for monitoring. The severity of vitiligo assessment, scored according to the body surface area affected. It is 2 scoring system, vitiligo area scoring system, BASI, and vitiligo European Task Force, BETF system. BASI, based on PASI scoring system of psoriasis, measures the extent and degree of depigmentation in 6 sites: hands, upper extremity, trunk, lower extremity, feet, hand or neck. And BETF, vitiligo European Task Force system, based on scoring system for atopic dermatitis, assessed the extent, staging, and spreading in 5 sites: head, neck, trunk, arm, legs, and hands or feet. The ETF grades from 0 normal pigmentation to 4 complete hair whitening. Spreading is assessed using the following score: 0 stable disease, -1 regressive disease, and +1 progressive disease. So conclusion in my part: proper history, clinical examination, and judicial investigation are important for diagnostic approach of vitiligo patients. And good news for vitiligo patient. Good news for vitiligo patient. Vitiligo patients may suffering from reduced incidence of melanoma, keratinocyte cancer, and internal malignancy in a study shows. And I welcome to you all. We have another program, South Asian Society for Sexual Medicine, in the 13th of this month. I am one of the speakers in that. It will be discussed about sexual transmitted infection regarding the male and female urethral discharge. So I invite you all in this webinar. Thank you. And this is Bishul Hafi and me in the Hungary during our scholarship. And Bishul Hafi have done tremendous job for organizing this scientific session. So I congratulate Bishul Hafi. Thank you. Thank you all for patient sharing.
Thank you, Dr. Mahmudur Rahman, for your informative and attractive presentation. Our next speaker is Dr. Mahbub Shaheen. He has a long experience in dealing with vitiligo patients. Today, he will highlight about the treatment modalities of vitiligo. Dr. Mahbub Shaheen.
Dr. Jasmine Lina, am I audible?
Yes, you are audible.
Okay, thank you. Thank you, Dr. Jasmine Lina. Thank you very much for giving me the opportunities to talk about the treatment modalities of vitiligo. First of all, I would like to thank Psychodermatology Society of India and Association of Cutaneous Surgeons of Bangladesh for arranging such a nice program regarding the very common disease. In fact, I can say in our country is a very neglected disease of vitiligo. So the treatment part of vitiligo is not so easy. It's a vast. So within a short period of time, it's very difficult to accommodate all the treatment modalities. But I'd like to briefly share the treatment modalities. So I am Dr. Mahbub Shaheen, vitiligo and hair transplant surgeon and senior consultant working in Aurora Skin and Hair Research Institute. So as you know, the treatment of vitiligo is always a big challenge for the dermatologist. Dr. Mahmoud very nicely and elaborately mentioned about the disease process as well as all other parts, including diagnosis. So most physicians incorrectly advise their patients that there is little or no hope. No need to treat this condition. It's not a curable disease. In fact, all these advices are well-meaning, but it's really discouraging and kill the patient psychologically. So mindset of both physician as well as the patients have to change. And this concept I actually share from the Bangladeshi perspectives. I have taken this experience from our patients that they actually believe that there is no treatment of vitiligo. Even most of our colleagues actually sometimes share with the patients that nothing to do, no treatments. Still, in our country, I cannot say we are in very much advanced stage of treating these conditions or in updated treatment, but though we are trying for the last couple of years. So a lot of things to do as a dermatologist, as a physician. So hopes and possibilities, if diagnosed early and treat properly, there is a chance of 70 to 80% patients with vitiligo experienced nearly complete repigmentation of their skin within 6 months to 1 year of time. So need to work with patience, honesty, dedication, sincerity, and efficiently in this field to manage a case of vitiligo. So treatment options are the psychological aspect, the most important part of the treatment of a patient of vitiligo, along with the phototherapy, medical treatments, procedural treatments, and surgical treatments. All it depends on the site of the lesion, size of the lesion, disease activity of the disease, along with many other conditions. So I don't go detail about the psychological aspect, as because our learned next speakers definitely will give you a lot of information regarding these topics. But counseling is of paramount importance. Really, it's very, very important to deal a case of vitiligo. So I don't go about this. So treatment is prolonged, and definitely it's not so easy. So required a sustained effort by the patient and the physician. So factors that influence the selection of treatment modalities are the disease activity, the site and size of the lesion, the duration of the disease, age of onset, comorbid conditions. So in active disease, for smaller lesions that involvement is less than 5% of body surface area, we actually choose the treatment modalities like topical preparations, excimer, and targeted phototherapy like narrowband ultraviolet B, which is suitable for both children as well as adult. If the active disease involves more than 5% of body surface area, then definitely narrowband ultraviolet B along with seismic drug is a very good treatment option. If the involvement is more than 50% of the body surface area, depigmentation is another option to treat. If the disease is stable, so surgery is the only option. So factors influence the treatment outcome: the site of the lesion, the size of the lesion, hair density, and the duration of the disease or lesion. So aim of the medical treatment is the psychological
Dr.
support.
Mahbub, would you
Hello.
please make your slide full screen?
I think the slide is full screen, Dr. Jasmine. It is full screen slide.
No.
No, it's not full screen.
It's not moving.
Your slide changing is not visible.
I'll share again, please. Is it clear?
Yes, yes.
Is it okay?
Yes, now okay.
Yes, now clear.
So the aim of medical treatment is the psychological support, stop the inflammation of the disease process and regenerate the pigment cells. So as you know, the source of melanocytes is a great source of the hair follicles, the bulge area of the hair follicles, and the dermal papilla. And as you know, how the treatments actually works in the vitiligo patients. So phototherapy, as I have mentioned, the narrowband ultraviolet B is now the phototherapy of choice for both the children and adult due to its safety profile and long-term treatment modalities. So along with the PUVA targeted phototherapy, examiner, and IPL as well. So narrowband is, as you know, that is a 311 nanometer wavelength, is very effective, safe, and it can use safely in both children and adult. Mechanism action, as you know, exact mechanism is not known, but it is supposed that it acts in two different ways. One is stabilizing the depigmenting process of vitiligo, and another is stimulating the residual follicular melanocytes to produce the pigment. So home phototherapy, as you know, that it's not actually always practically feasible for the patient to come in a center twice in a week or thrice in a week for a longer period of time to get the phototherapy. So home phototherapy is a very good alternative options. And in 2006, a Canadian study shows it's a very suitable treatment options for the small lesions if the patient's compliance is very good, and definitely it's very effective treatment as well. Excimer system is, as you know, 308 nanometer and particularly suitable for small lesions and facial lesions. And response is very quick. And from my experience point of view, it's really wonderful options for the treatment of small lesions, particularly in face of the children. So topical treatment, as all of you know, these are the topical corticosteroids, calcineurin inhibitors, and topical tacrolimus, calcipotriol. That actually I have mentioned earlier. If the body surface area involvement is less than 5%, then we can use these treatment modalities. And camouflage, all you know, sometimes we advise patients to use the topical camouflage, or permanent camouflage is scalp micropigmentation and tattooing. Systemic treatment, as you know, there are a lot of systemic treatment modalities are available along with corticosteroids, methotrexate, azathioprine, and new treatment options is a JAK inhibitor. That is really wonderful treatment options. And I have been experience of more than 3 years. For last 3 years, I using this drug in the management of vitiligo as well as hair loss patients, and found is a very good drug with efficacy and safety profile. So systemic steroids, dexamethasone, oral mini pulse therapy. If more than 16 years old patients, this protocol is 5 milligram per day, 2 consecutive days a week. And if it's less than 16 years of age, half the dose. And dose may be increased up to 10 milligram per day, and tapering is needed accordingly. So these treatment modalities can actually arrest the disease activities in 89% cases within 1 to 3 months. So, and found is no disease activities are at least 1 year. And repigmentation in 80% cases of active disease within 2 to 4 months, definitely along with narrowband ultraviolet B phototherapy. So maximum duration of steroid we can use 24 weeks safely as a pulse therapy, and oral mini pulse therapy with narrowband is definitely better than only oral mini pulse. And if we compare the single narrowband, it's definitely better than oral mini pulse therapy, steroid therapy. So oral mini pulse steroid therapy is not effective in a stable vitiligo to make it repigmentation. So should not use this drug in a stable vitiligo patients. And as you know, phototherapy, narrowband ultraviolet B has a very less side effects except the burning, blisters, pain, or scaling. Minocycline is very interesting. It's a new drug. As you know, it's an antibiotic and having similar stabilizing effect like oral mini pulse therapy of steroids. As you know, steroid has a lot of side effects, but this is the antibiotic. Minocycline is safe and less side effects. So study shows it's a very effective drug. Using 100 milligram daily for 3 months. Found one study found a good result because of its anti-inflammatory, immunomodulating, and free radical scavenging action. All these are have we found in the pathogenesis of vitiligo. The other immunosuppressive drugs, methotrexate, azathioprine, limited study in methotrexate 10 milligram, which is comparable to oral mini pulse steroid therapy to stabilizing the disease. Azathioprine we can use 50 milligram is effective along with phototherapy. JAK inhibitors mentioned as it has an anti-inflammatory properties along with narrowband ultraviolet B phototherapy is a wonderful result within 3 to 6 months to stabilizing the disease or to inactivate the disease process. That is really very important. As you know, this 5 milligram and 11 milligram tablet is available in Bangladesh. So lipid lowering agent, I don't have too much experience, but some study shows its immunomodulating and anti-inflammatory effects have some role in the management of vitiligo. And some vitamins, B12, folic acid, D, these have some sort of role in the pathogenesis of vitiligo. So treatment with these vitamins along with combination with phototherapy, narrowband ultraviolet B or PUBA have found some efficacies. Ginkgo biloba, as you know, it's a phenyl compound, has the anti-inflammatory, immunomodulating, and antioxidant properties. So some studies shows promising result, but as because there is inconsistent outcome and limited studies, that's why it's not still the drug to establish the treat a case of vitiligo. Zinc is really is a promising agent in the treatment of vitiligo by preventing the apoptosis of melanocytes, as you know, the basic pathophysiology of vitiligo is the destruction of melanocytes. So I think zinc may be a good adjuvant treatment along with other treatment modalities. In depigmenting therapy, refractory vitiligo, particularly if the involvement is more than 50% body surface area, then we can go for this chemical depigmentation or physical depigmentation. I have a little experience of physical depigmentation with cryotherapy and found is good, not bad at all. So procedures, as you know, these are the new treatment modalities for the management of vitiligo. One is microneedling therapy along with narrowband or topical tacrolimus or 5-FU, which actually stimulates the melanocytes proliferation and migration. And PRP, as you know, it's a very favorite treatment modalities for the management of hair loss disorder as well as other dermatological conditions. Even there are some studies that it works in the management of vitiligo, particularly the growth factors that suppress the pro-inflammatory cytokines release and limiting the inflammation of the disease process of vitiligo. Surgical management, as Dr. Mahmood nicely mentioned, total Indian study shows 2.5% population in India are affected by vitiligo. So there is still no data in Bangladesh. If we consider the same prevalence of cases in Bangladesh, it's near about 50 lakh people are affected with this disease. And more than 10% are segmental in nature, as Dr. Mahmood nicely mentioned, the types of vitiligo. Within a short period of time, the most positive thing of segmental vitiligo is within a short period of time, they become stable. So near about 5 lakh patients are suitable for surgery, as considering the segmental vitiligo concerns. Even some non-segmental vitiligos, if they become stabilized, definitely we can select the patients for surgery. So success rate of these different surgical modalities are 50 to almost 100%. So in Bangladesh, considering the number of cases, a lot of dermatology surgeons are needed in this field to work with this group of patients to give the surgical management. As you know, it is a special work and need training and need experience. So surgical treatment modalities are two types, as you know, tissue grafting and cellular grafting. Mini pulse grafting is a very old method, early method, along with suction, blister epidermal grafting, split thickness skin grafting, follicular unit grafting, and Jodhpur technique. And cellular grafting is non-cultured melanocyte and cultured melanocyte techniques. So according to the area of involvement, actually the method of surgery is selected. So in small area, epidermal grafting is a very good mini grafting, suction blister grafting, mesh grafting, sometimes non-cultured melanocyte, but non-cultured melanocyte treatment is very suitable for medium and large area of involvement. And according to the site of involvement in finger and toes, mini pulse grafting is suitable. Palm and sole, mini pulse grafting, eyelids, NCMT, split thickness skin grafting. In case of nipula and areola, we can use all these techniques, including NCMT, split thickness skin grafting, and mini pulse grafting. In genitalia, we can also do suction blister grafting and non-cultured melanocyte transplant as well. So mini pulse grafting, I don't go detail about this because of shortage of time. I just give you the overviews of the procedures. This is mini punch, 1.2 to 1.5 punches are uses, and in between the grafts is 0.5 to 10 millimeter. And donor area, as you know, the same donor area, lateral or upper respectogluteal areas, and same punches are used both donor and recipient areas. I don't go details about this. Phototherapy is very important for after this mini pulse grafting. Advantages are is very easy, and for the beginner who are interested in the field of vitiligo surgery, it's a very good techniques for them. Easy, fast, and least expensive, and can perform any site of the body except the angle of the mouth, and suitable for areola and palm as well. But the problem is there is some sort of disadvantages. Is cobalt stoning after surgery, phototherapy is needed after surgery, color matching may not satisfactory for the patients. Ultra-thin skin graftings, as you all know, is taking the skin, and advantage is easy, simple, cost-effective. No need to specialized equipments or technicians. And difficult area can be treated like eyelids, lips, areola. Less time is needed. It's a very good color matching. Disadvantage is surgical skill is very important, and multiple sessions for larger area. And hyperpigmentation sometimes occurs, and donor recipient ratio is 1:1. So you cannot cover at the same time a larger area. Suction blister grafting, as you know, this you cannot go details. Advantage is simple, easy, inexpensive, the good success rate, but not suitable for larger area, and it's definitely time consuming. Non-cultured melanocyte transfer, I will go a bit detail about this. As you know, the surgical procedures, pre-operative and post-operative. Pre-operative, as you know, proper counseling, intermittent constant, vital parameters, pre-operative photography, all these things before surgery is very important. And pre-operative steps are first of all shaping the donor area and then giving the anesthesia. And after anesthesia, we are taking thin grafts from the donor area, and then graft is harvested and keep it in a petri dish containing saline. This is a very good graft taken from the donor area. And then grafts are cut in small pieces and then taken in a test tube, which is containing trypsin solution, as you know. About the trypsin solution, and then grafts with this test tube incubated in 37 degrees centigrade for 45 minutes, 1.5 hours. And then the suspension is separated by filtering, taken in a test tube, and finally suspension is mixed with serum taken from the patient, and then test tube with melanocyte keratinocyte cell suspension centrifuge for 10 minutes at a rate of 2000 RPM to obtain the cell pellets, which is our goal or target at the bottom. Just look at the cell pellets that is mixed with serum. And finally, this serum, this preparation is prepared for the application to the recipient area. And as you know, before applying this, the recipient area should be prepared by dermabrasion, whether you use motorized dermabrader or use manual dermabrader up to the pinpoint reading. And then you put the cell suspension and spread evenly on the dermabraded area through the pipette properly, and then finally you go for the collagen dressing followed by adhesive bandage. And advise the patients to complete rest and avoid all vigorous physical activities. And advising taking oral antibiotics and NSAIDs for a week. And dressings are removed after a week, and patients are followed up accordingly: 1 week, 1 month, 3 months, 6 months, and 12 months thereafter. Post-operative measurement is very, very important. Oral medications, 24 hours immobilization, elevation of the extremities if lower extremity is involved, and keep the dressing dry. And remove after 7 to 10 days. Initially, the areas become big, and repigmentation usually starts 2 to 3 weeks after the procedure, and it's pigmentation completed after up to 12 months. So it is almost a uniform color. So counseling to the patient is very important. Sometimes repigmentation will take even 12 months of time. So in a few cases, there are some hyperpigmentation which will improve sleep time. And phototherapy, after 2 weeks of surgery, you can start phototherapy to enhance the repigmentation process. And post-operative assessment is by subjective as well as digital photography. And subjective assessment is done by asking the patients as you accordingly. 0 to 5% is poor, good is 26 to 75%, excellent is if more than 75% repigmentation is occur. Digital photography is taken after a week, months, 3 months, and finally after 6 months and 1 year of time. And results are considered excellent if it is more than 76% repigmentation can achieve in 89% patients. And I'd like to share some of my experiences. This is case 1, before and after surgery. This is case 2. This is case 3. This is case 4, before and after surgeries. So all these reports, results are actually getting after 6 months of surgery. This is another case. So this is another case. It's a really very good color matching and definitely satisfactory to the patients. And it's wonderful results considering the patients' satisfactions. So this is another case of segmental vitiligo, which result is wonderful. As I have mentioned, segmental vitiligos are suitable cases for surgery after stabilization. So adverse effects, not so many adverse effects are if you do it properly. Prognosis, if you do less than 100 square centimeters in a single session, the outcome is very good. Repigmentation ranges 76 to 100%. Why NCMT is superior than tissue grafts? Considering the all surgeries, NCMT is definitely superior due to its excellent cosmetic results, color matching, minimum donor skin, that is 1:10, that is larger area to cover larger recipient area, affected area. This is a very good treatment option with maximum area coverage. Immobilization is usually not necessary, and topical anesthesia is sufficient. No stuck on appearance, no cobalt stoning, no polka dot, which is actually found in other surgical modalities like punch grafting or like that. These are the features of cobalt stoning, very graft halo and stuck on appearances. So disadvantages of this procedure is expertise is very important, while training is needed, and well-equipped labs instruments are needed. Trained persons are required, and definitely it's a bit expensive than other procedures. So first time in Bangladesh, the workshop on non-cultured melanocyte transfer in vitiligo surgery held in the Aurora Skin and Hair Research Institute in January 2019. And Dr. S. Hayat Nagarkar, he was the keynote person. He's a very dynamic and very good person. He's basically the pathologist, but he's an inventor of the NCMT kit, as you know. And I am actually using this kit for last more than 2 years, all my cases, and found is a very good results. And after that, in March 2019, the first international conference on vitiligo surgery, where the keynote speakers was Dr. T. Salim, Sanjay Dubey, and S. Hayat Nagarkar. All they are very much renowned about in their field of vitiligo surgery. So take-home message is it's a treatable condition. If diagnosed early and treated properly, prognosis is really satisfactory. So thank you, everybody. Thank you very much for patient sharing. Thank you. Thank you.
Thank you, Dr. Mahabub Shaheen, for your very informative, elaborative, and also instructive presentation. Now, I would like to request Professor Dr. Sendhil Kumaran to share his experience about the psychological aspect of vitiligo in Indian subcontinent. Professor Dr. Sendhil Kumaran, sir.
Good evening, everybody. At the outset, I would like to thank the local organizers as well as the PDAI for giving me an opportunity to talk over here. And continuing with this Vitiligo Day celebrations, my topic for today, which was given, was psychosocial impact of vitiligo in Indian subcontinent. And let's see what's there in it. I have no conflicts of interest to disclose. And we all know that patients with pigmented disorders can be perceived as different from rest of the society, resulting in great psychosocial stress. And skin and mental health. Now, what is that? We know skin is like a mirror. It plays an important role in our interaction with the world, and skin color is an important element of perception of one's health. So a perfectly normal skin is essential for a person's physical and mental well-being, an important aspect of their sexual attractiveness, a sense of well-being, and their self-confidence also. So the skin is the largest organ we know and the most visible one too. So in that sense, so any change in that skin may have a severe psychosocial consequences. So especially a change in the skin color in this present digital age can often be very exacerbating to the person, changing the way they behave, the way they perceive themselves, and also leading hence finally leading to stress and psychosocial or psychological comorbidities. People with Fitzpatrick skin types, type 3 to 5, are more plagued with these various pigmented disorders and abnormalities, including vitiligo. The current literature is unequivocally suggests a link between skin disorders like vitiligo and psychological distress. So a brief introduction to vitiligo per se. Vitiligo, a common acquired depigmenting disorder affecting approximately 1% of the population worldwide. It is clinically characterized by well-demarcated areas of depigmentation as a result of loss of melanocyte. Most of the has been covered in the first and the second session, so I'll not be going much detail in it. And vitiligo is associated with many autoimmune and autoinflammatory conditions that we may be owing to the shared genetic susceptibilities. This is the small graph which was showed in the first presentation also. So this is the graph which shows in the person who's about to get vitiligo or in the presence of a genetic susceptibility to getting vitiligo, the presence of many factors like genetic defects, autoimmune factors, nervous system defect, oxidative stress, and all these things finally leads to the pathogenesis of vitiligo. However, the exact etiology is still elusive. And these are the group of associated disorders, which I said because of the similarities of the genetic susceptibility, they can be present with vitiligo. And some of the ocular and auditory abnormalities, I just give a passing reference to it because wherever the melanocytes are there, a vitiligo patient can be affected. And presence of ocular and auditory abnormalities occur in association with vitiligo owing to the presence of melanocytes in these tissues. And vitiligo patients can have profound auditory abnormalities in more subtle form owing to the alteration of the melanocytes. Clinical studies showing that shows that 12 to 18% of vitiligo patients have a sensory neural deafness, and vitiligo patients may also have ocular abnormalities that can affect the iris and retinal pigment epithelium, resulting in uveitis. So the aim, the management was already said by the previous speaker. The aim of the vitiligo treatment is to get a better skin appearance, but it requires quite a long time. It might be as long as 6 to 18 months. But however, the response to treatment is about only 70 to 75%. And how to choose a treatment modality depends on the severity of the involvement, the extent of vitiligo, as well as the location of the disease. And we use something called as the VASI, that is the vitiligo area scoring index, is one of the most valid indexes for the evaluation of disease extent and severity, and also it can be measured in all situations. So coming to the crux of whatever I had to present, that is the effect of vitiligo on quality of life. Although generally considered to be a cosmetic issue, vitiligo can have a major impact on the quality of life and the self-esteem, especially in the dark-skinned individuals. And presence of depression, anxiety, and other psychiatric comorbidities are common in vitiligo patients owing to its chronic nature of the disease, its associated stigma, the refractory nature of the illness, frequent relapses, which it usually does, and unpredictable course of the disease and need of long-term treatment. So evaluation of a disease based only on clinical assessment, which most of we dermatologists do, does not capture the disease impact adequately. So we need to delve deeply into the other assessment of its impact on quality of life and mental health also, so that we fully, holistically address the need of the vitiligo patient. Coming to the I think the stigma associated with the vitiligo is possibly more severe in the colored races inhabiting most of the developing countries like India. It is very common in our country. And wrong social beliefs, the myths, it's very common in between people like us. Even I think so it might be there in Bangladesh also. These are the common things which exacerbates the problem of vitiligo patients. And in India, sometimes vitiligo is considered as white leprosy, which is known since ancient times of Rig Veda period itself, and which is the cause for the significant stigma. And according to literature, vitiligo is considered to be both the cause as well as the result of some psychiatric problems like anxiety and depression. Thus, a history of other psychiatric problems could potentially add to the burden of this disorder. The patient with vitiligo often suffer a financial loss. Why? Because most of the time we advise a phototherapy for the patient. So either the patient, it might be person itself who will be a daily wages work, he has to suffer as a business loss or whatever is that day wages, so he has to come for the therapy. Or it might be his kid who is suffering from vitiligo, so they have to skip their work to come and take phototherapy. So all these adds to the financial burden also because and have to take time, as I said. And vitiligo lesions over exposed sites can adversely affect the person's chances of getting a job at an interview also. So because of which he has to rethink and which of the job is correctly for him. The compliance for regular long-term visits for POVA, narrowband UV therapy, side effects and immunosuppressive side effects of immunosuppressive therapy, a long-term risk of photoaging and carcinogens with phototherapy are other limitations for the vitiligo patients we have. And Al-Abdi et al. Indicated that the psychological stress increases the level of neuroendocrine hormones, which indirectly affects the immune system and alters the levels of neuropeptides. These alteration in the neuropeptides will other hand go to initiating the event of pathogenesis of vitiligo per se. So this is a circle of life sort of thing. So it is a circle of vitiligo there. And Papadopoulos et al. He was a very initial person who suggested the need to look into the quality of life of the vitiligo patient. He suggested that counseling can help to improve the body image, the self-esteem of the vitiligo patient, and our quality of life of patients, also having a positive effect on the course of the disease. So this he suggested way back in 1999 itself. So vitiligo involving the face and hands have the greatest impact in cure, because we know it is coming on the most exposed side, probably as a result of it is visibility in nature and inability to cover ourselves. We know we cannot cover our face and hands together always. And increasing age. Other factors are the increasing age, the presence of female sex, and presence of or absence of positive family history are associated with significantly increased severity of vitiligo, probably due to the underlying genetic factors and HLA haplotypes. And patients with early onset of the disease, those having previously taken any kind of treatment, and unmarried individuals especially, have a significant effect on the impact on the quality of life. Other general factors which affect the quality of life are the age at onset, which I already said, the skin phototype, I said 3 to 5, the darker the skin type, the more is the impact on the quality of life. Extent and distribution, that is if it is on the outside and exposed areas, and larger distribution has a poor impact, and impact of treatment also, as I said, with the presence of phototherapy, or when you're giving immunosuppressants, the side effects of immunosuppressive therapy. Noguria and his colleagues found that most vitiligo patients with affected areas on exposed complain of negative emotions as compared to those with the lesions on unexposed areas. So this is one of the findings. And among the emotions related to the disease they found was the fear of spread of the disease, which was spread in 71% of the patient, presence of shame, because the shame, whether it is self-perceived or because of the surrounding people who try to shame the people, that was present in 57% of the patients. Presence of insecurity in 55%, sadness in 55%, and inhibition to the outside world was present in 53% of the study cohort. Similarly, Prasad et al. From our institute and his colleagues found that the lesions involving the face, arms, legs, and hands had a higher impact on the dermatology life quality index. So coming to the vitiligo impact in India, I did actually go through how many studies have been done on the impact of quality of life, as well as on social impact on vitiligo. Very limited studies found, not too very standard studies also, as few which has come out abroad. So I'll try to share very few of them with you, the important one at the last of this presentation. So these are the very initial thing. Vitiligo referred to as Shvetakwistya or white leprosy in India, and is disfiguring in all races, but particularly more so in dark-skinned people, because we Indians are more or less dark-skinned. And India and perhaps elsewhere also, men, women, and children with vitiligo face severe psychological and social problems. And our Prime Minister, first Prime Minister, Pandit Jawaharlal Nehru, ranked vitiligo as one of the three major medical problems after leprosy and malaria. So in India, vitiligo, commonly known as leukoderma, is unfortunately associated with religious belief also. Maybe whatever is thing, it is a problem even in Islam, as well as Buddhism, as well as in Hindus also. Thus, people suffering with vitiligo in India have more social problems than any other countries. This is seriously felt among young unmarried women. Thus, a young women with vitiligo has little chance of getting married. And this is the history which I already said. Coming to the more crux, let's see what happens in children. Is there any effect in children? Because most of the time, children are very bubbly and think they hardly bothered about the disease. Let's see what happens in childhood. So vitiligo beginning in the childhood can be associated with significant psychological trauma that may have long-lasting effects on the personal self-esteem of these children. They have tried to divide the group of children, those who are below 10 years and about 10 to adolescent age. So they have found the more impact on QAL on the people who are more of the adolescent age, that is 10 years and above. So children with vitiligo usually avoid sport and restrict such activities. Children often lose vital days from school. Parents of children with vitiligo may have take time off their work to regularly accompany them for the hospital appointments. And children with vitiligo deal with the disease well or be devastated by it, often depending on the attitude of the parents. This is more important. Most of you in your own practice, you have seen, rather than the child being worried about the disease per se, it is the mother and or the parents who are pouncing on the doctor to asking them to give a very good effect on children. and whatever stress they are having, they in turn put on the child, and the child suffers because of it. So here in this case, not only the counseling of the patient is important, it is the counseling of the parents too, which is doubly important, so that we save unnecessary trouble on the child. Of note, a recent review article on quality of life issues in childhood skin disease for those with vitiligo experience low self-esteem, social stigmatization, and avoidance of intimacy, anxiety, depression, adjustment disorder, fear, suicidal ideation, and other psychiatric mobilities. It was by Brown et al. In Dermatology Clinic in 2013, and another internet-based survey of children aged 0 to 17 years and their families. So they show the quality of life impairment increased with age, which I already said. Indeed, more than 90% of the adolescents 15 to 17 years were bothered by vitiligo versus 50% of children who were aged between 0 to 14 years. So as Brenny Rice once said, she's a famous TV actress, the definition of beautiful doesn't mean that you are perfect. It means loving and accepting yourself for how you are is uniquely made. So this is a very important message to all the vitiligo patients that you can share. And coming to the tools, because these are important, which will tell you what is the psychological impact on the patient it has. We have a lot of health-related quality of life indexes in pigmented disorders. They can be classified into three, that is the general health questionnaires, the dermatology specific questionnaires, which can be used in other dermatology disorders also, and disease specific questionnaires. And since pigmented disorders affect social and psychological well-being of the patient more than the physical, therefore it is important to have a specific tool to assess the quality of life in patients with pigmented disorders. So these are the things. So general questionnaires will have short form 36 item health survey, the Eurocall we have, the Rosenberg self-esteem scale we have. For a dermatology specific, we have DLQI and a skin 7-item skin discoloration questionnaire, and more, which is specific, is vitiligo, which is commonly used all over the world questionnaire. The VIS, vitiligo impact scale 27, which was the old one, and now the modified variant of 22, which has come from AIMS in New Delhi. And we have the VLQI, that is vitiligo life quality index, which is more specific if you want to deal with the extent of the disease and how much it is affecting the quality of life of the patient. So some of the things. So these are the health domains of some generic and dermatology specific. Why we need not a generic? Because they'll have something called as physical functioning, which is not very characteristic for our thing. So that's why we need specific tools. So detection of quality of life in vitiligo. The quality of life and burden of vitiligo may be measured by generic instrument like DLQI or specific instruments, which I already said. Although the generic instruments such as DLQI or short form 12 may provide a general picture of impaired quality of life, they usually fail to detect nuances in how patients deal with overall vitiligo burden. So because they only say the topical superficial thing, they don't go much deep into it. So coming to just a few words, I'll not put too much of take too much of time. DLQI is developed in way back in 1994. Was the first dermatology specific quality of life instrument. It has been used for more than 40 different skin conditions in over 80 countries and available in over 90 languages across the world. Its use has been described in over 1,000 publications, including many multinational studies. And the DLQI questionnaire is designed for use in patients for age more than 16. Please look, it is age more than 16. And DLQI question is classified by 10 questions, and each question with 4 possible answers scored by 0 to 3. And the higher the score, and higher the score, the more the quality of life is impaired. So this is how the interpretation is, as it is shown in the table. And this is the questionnaire which can be found online itself, the DLQI questionnaire. Coming to the childhood DLQI, this is very specific if people are dealing with the pediatric vitiligo, childhood vitiligo. The CDLQI questionnaire was published in 1995 with 10 questions are based on the experience of children with skin disease. Each question is illustrated by a cartoon because most of the time the children like to look at the cartoon and to answer it. And here also they try to differentiate two, one with the cartoons, one without the cartoons, because the elder children do not like with the cartoons. So the only difference between the two formats was the cartoon version. And however, both the versions are fully validated. So people, if you want to use in your research, you can use that. And there is no difference in how responding answers format scores may be compared in any analysis. So both versions of CDLQI have been validated from the age of 4 years to 16 years. And however younger the children may appreciate using the cartoon version more than the older children. And some teenagers may find cartoon version too childish, which I already commented on. This is the CDQL childhood DLQI version. If anyone wants to, it is there on the thing. And coming to the more specific one, what is the vitiligo impact scale, which was designed to measure the impact and appears to be the second instrument developed exclusively for vitiligo. It had 27 easily comprehended items, which makes it simple and quick to answer. The correlation of the scale scores with DLQI and skin index 16 indicates that it is a valid measure of the burden of vitiligo. So it's a very important one. And VIS appeared to perform better than both DLQI and skin index in many of the studies in delineating the patients with very mild thing, because it is a specific scale. So even the mildest change in the patient's QL, it is able to fetch. So no such advantage was seen when we compared moderate and other severe distress. So this is the thing, vitiligo impact scale of having 27 questions. Coming to 22, this modified 22 scale was published by the group from AIMS, where they decreased it to 22 items, which covered the domains of self-confidence, anxiety, depression, marriage, family worries, social interaction, school, college-related, occupation-related, treatment-related, and attitude variety. And the scores VIS 22 worsened significantly with clinical worsening. So this is the, if it is there in a BJD 2014 publication, if anyone wants to use this vitiligo impact scale 22. Coming to vitiligo, this is the most validated and used in many multinational studies, health quality instrument, specifically in patients with vitiligo. It can also provide an objective measure of the disease status, burden of disease, and treatment outcome. Vitiligo is designed to be used clinically to assist the physician in the identifying the aspects of health, quality of life that are important to an individual patient, along with providing an objective measurement of the disease status, the burden of the disease, and also the outcome of whatever the treatment the patient is taking. So vitiligo has three domains. What all it is: participation limitation, stigma, and behavior as per a QLVR. This is the vitiligo questionnaire. It was published initially by Lilly et al. In JAD 2013. Skin index, it's also one of the specific one, but not much used because of its complexity. And this is the it is very old, came by way in 1996. And more specific on which is a vitiligo life quality index, I said, which has been proven to be a better reflector of quality of life, especially than DLQI. It has a significant relationship between the extent of the disease and the impact on the quality of life. The bigger the area affected by vitiligo, the more severity is the impacted quality of life. This is the questionnaire of DLQI. It was published by Seno et al. In Dermatology in 2013. Now, once this one, I tried to look into what is the published data regarding any good studies which is there from the Indian subcontinent. I came across one study which was from our institute itself, wherein they studied the psychiatric morbidity in vitiligo and psoriasis. It was a comparative study from India. The objective of this study was to assess treatment-seeking patients with vitiligo and psoriasis, the prevalence of psychiatric morbidity in both of the diseases, how far psychologically were they affected, whether they had a psychopathological profile, or whatever their demographic, and correlates with the psychiatric morbidity. And they use this questionnaire, that is the GHQ-12, that is a general health questionnaire. It is a screening instrument for assessing psychiatric morbidity. It is validated in Indian population. Present study in 12 items taken from Hindi translation also of the 60 items GHQ. Hindi version is also there. Back translation into English was also done for people who do not understand Hindi. And test thing. Any person scoring greater than or equal to 3 was defined as a case with psychiatric morbidity. This is another one used, that is the attitude to appearance scale. This was introduced by Wesley and Lewis, which developed the scale. There are semantic differentials based on dysfunctional attitude scale of Beck. It also has 5-item yes or no response scale. Possibility score ranges from 0 to 5. Higher the score, indicating more perfectionist attitude. So this was the results from the study. Now, what did the results say? It were among this total there were 113 vitiligo patients, 38 of the 113 vitiligo patients being GHQ positive. That is higher score, which showed a higher impact or psychiatric morbidity impact. Clinical prevalence rate of psychiatric morbidity was 33.63%, and GHQ positive vitiligo subgroup were more often younger patients, those who were unmarried, and more common in female subjects, which was statistically significant. And significant correlates of psychiatric morbidity in GHQ positive cases were seen. And in vitiligo, GHQ, CPRS, and other impact scores were also significantly showed a psychiatric comorbidity in the vitiligo patients. So breakdown, which was found, they found apart from the depression thing, they also found the patients, 13 patients had an adjustment disorder. That is true where the place of work as well as in their family surrounding. Second one, depressive episodes was found in 5. And dysthymia, this I did not get in any other studies. This study reported the presence of dysthymia in 2 patients and no psychiatric comorbidities in 3 patients. So this I would like to address because Wesley and Lewis argued that the favor of the physicians and dermatologists acquiring skills. That is, earlier we are able to identify the impact on quality of life, and initiating a proper management of psychiatric comorbidity is required. So this recommendation shows that low dose antidepressant, proper counseling and supportive group therapy will help in alleviate the psychiatric comorbidities which the vitiligo patients usually carry. So coming to the conclusions, or what we can call as the take-home messages, increased awareness of quality of life issues will help to ensure that vitiligo is no longer dismissed as a cosmetic or an insignificant disease. Although it has been there since many years, dermatologists are often focused on only giving remedy and for cutaneous lesion and sending the patient away. Sit with the patient, spend time, holistically approach, and give a psychiatric good counseling to the patient so that the treatment which the doctor is giving is being perfectly followed without any complications. And also there is often a negative stigma associated with psychiatric disease. Therefore, the patient often refuses to a referral to a psychiatric department, because if suddenly you say your psychological effect, no person will want to go. So there the dermatologist itself have to be proactive and try to address the patient in a holistic manner. In such situation, the onus of screening and psychiatry falls with the dermatologist, which I already said. And these are the few questionnaires which are there on thing available, which will help as the screening tools to see whether your patients are suffering from secondary psychological comorbidities. And it is important to recognize and deal with these components so that to improve the quality of life, because every patient, if we take as though it is ours and treat, will get a very good positive outcome. And this is one thing which I wanted to share. This is a Pigment International Journal, which we have it in India, which is for pigmentary disorders. We have it is a indexed journal. So the researchers from Bangladesh who are doing a lot of research work in pigmentary disorders can use our journal for publishing. And thank you.
Thank you, Dr. M. Senthil Kumaran, for your very valuable, enthusiastic, and also insightful deliberation.
Thank you, Dr.
Now, our last speaker is Professor Dr. Abdul Latif. I would be honored to request him to speak on psychodermatological management of vitiligo. Dr. Abdul Latif, sir.
Very good evening to you all. Hope I am audible.
Yes, sir, you are audible.
So after the 3 exhaustive and elaborative talk, my presentation is very easy now. We know vitiligo is a common skin disease affecting 1 to 2% of the general population. And the various pathogens is already mentioned. But there is one type of vitiligo that is called valencia type of vitiligo, where a sudden onset, rapid progression of vitiligo induced by stress. So stress per se can induce vitiligo. Then the psychiatric morbidity in vitiligo in various studies, the various statistics and study results already you have heard. So you can see stress is thought to be a major etiological factor in 1/3 of vitiligo cases. Then psychiatric morbidity in vitiligo patients ranges from 30 to 60%. Adjustment disorder, anxiety, depression, these are all very high in various studies. Then other studies also showing the psychiatric morbidity almost 79.2%, and depression and social phobia, these are all very high in various studies. And various studies are showing the depressive episodes, anxiety, adjustment disorder, these are all very common, and the stress is mainly present in unstable vitiligo comparing to the stable vitiligo. And so many day-to-day life stress events, they are responsible for the vitiligo. That may be personal or familiar or work-related or health problem, or multiple stressors will be there. All can lead to mental stress, and they are responsible for vitiligo. And various studies are showing dark skin people are more prone for psychological stress in vitiligo, and short duration of the disease is more problematic. Unstable people are more prone for mental stress, and depression is high in middle and lower socio-economic class of people belonging to these classes are very high. So the various psychological problems you can get in vitiligo include: one is stress about the disease, then there will be irrational fears, and body image disturbances will be there, and increased frustration about the disease and to involve in the society, and negative thoughts about the disease, and there will be decreased self-confidence and self-esteem. Then gradually they will withdraw from the society, they will sit idle in their own house, or they will gradually withdraw from the social environment. And there will be sleep problems, and there will be relationship issues, especially in the family, in the marital life, and other emotional outbursts like anger and shame. And there will be stigma in the society, and that's why they will not be able to go outside, and the people will discriminate them, especially social discrimination is very high, and they will gradually get isolated, social isolation, especially in the familial situation and in the school and colleges. And there will be socio-occupational impairment. They may not be able to work properly in the same environment. So gradually they will withdraw from the occupational area. So ultimately that will affect the quality of life, may lead to anxiety, depression, suicidal ideation, and there will be other adjustment disorders, compulsive disorders, somatoform disorders, and hypochondriasis. So a psycho-intervention is an essential part of vitiligo management. So we need a psychotherapy and pharmacotherapy in some cases. So psychotherapy, the various goals of psychotherapy: one is to strengthen the coping mechanisms, enhance self-esteem, prevent social withdrawal, and treat anxiety, depression, sociophobia, other psychiatric comorbidities. So there are so many psychotherapy procedures, so out of which the important ones are: one is psychoeducation, cognitive behavior therapy, relaxation therapy, group therapy, family therapy. Then we can use hypnotherapy, guided imagery techniques, breathing therapy, then transactional analysis, neuro-linguistic programming, then psychoanalysis, they can be used. And another important area is social skill training, especially the assertiveness training, then behavioral therapy like desensitization technique, especially in case of anxiety and phobias. Then we have to teach them coping strategies and intervention to improve self-esteem. And ultimately, in those people where the treatment will be very difficult, we should empower to live with the disease. So psychoeducation is very important aspect of vitiligo management, especially the psychological management. So here, there are so many anxieties regarding the disease. One is regarding the etiology. Some people believe this as the wrath of the God or some punishment by God, or they will have their own precipitating concept regarding their own precipitating factors. And the role of stress, we have to mention the role of stress. And some people think it is a contagious disease that will be producing problem in their family, in their marital life. And the various treatment options we should tell them. and the consequences of the disease and the prognosis. All these things you should discuss in your psychoeducation. And we have to tell them the patient's problem is not a rare case, because they are thinking this is a very rare disease affecting only 1 or 2 people. And the genesis of the disease you have to mention. And you have to tell them this is unpleasant, but this is not dangerous. That will not produce any harm to your body. And your help and treatment are available. And you have to mention your life experiences, your previous therapy experience, successful therapy experiences you can share to the patient. So this is very important. In many, almost 50% of the problem you can solve, the psychological problem you can solve by simple psychoeducation. Then the cognitive behavior therapy, here the thought process and the resultant action is modified. So it is not always the disease that is stressful, but how do we perceive them? That is very, very important. Because some people with vitiligo, you may be seeing, not only vitiligo, any disease, there will not be much stress, because their perception will not be that much very bad. But other people, they will think this is a very serious illness, contagious disease, then people will hate me. So depending upon the perception, their stress level will be varied. So in cognitive behavior therapy, what we are aiming is to change the way of thinking. So there are several approaches of cognitive behavior therapy. The one, rational emotive behavior therapy, that is one way. Here, this is a form of cognitive behavior therapy in which the client is encouraged to examine and change the irrational thought patterns. So rational thinking means and beliefs in order to reduce the dysfunctional behavior. So an irrational thinking is what type of thinking are problematic to the human beings. They are irrational thinking. So that will lead to the irrational thinking, will lead to emotional disturbances. So for example, so irrational thinking, a student, there will be an adverse event, and that will lead to some beliefs, some thoughts, attitudes, and assumptions. And ultimately that will lead to the psychological consequences like feelings and emotions. For example, a child fails in the exam. He thinks, I'm stupid, I will never be able to pass this exam. So that will lead to depression. But at the same time, the same child is thinking, I failed the exam, that's right, but that's unfortunate that I failed. I did not study hard due to some other problem. So I can pass next time. If he's thinking like that, there won't be any emotional consequences. Similarly, in vitiligo, if the person is thinking I have got a white patch, people will think it is contagious and they will hate me. That will lead to social withdrawal, anxiety, and depression. But he's thinking that I have got a white patch, but the white patch, like the paint that is lost from the wall, paint of my skin is lost, there won't be any problem. So there won't be any emotional consequences. So you can see this is our governor in Kerala state of India. He had extensive vitiligo. He used to attend all the functions, but he had no problem with self-esteem or no other emotional consequence. So that is why, depending upon the perception of the individual, that's very important. And the cognitive behavior therapy try to or help in changing this cognition. Then comes the behavior therapy or behavioral psychotherapy. This is a broad term referring to use techniques to treat for the treatment of maladaptive and learned habits. So behavior therapy aims to promote healthy behavior and eliminate unhealthy behavior. There are so many techniques, but here in vitiligo, one important area is one is systematic desensitization. That's very helpful, especially in conditions of fear, phobia, and panic reactions. Especially people, they may not be able to go outside to the public. In such fears and phobias, we can utilize these systematic desensitization techniques very usefully, so highly useful in such people. Then comes the family. So here the concept of the family therapy, we have to involve the family in the treatment, because the concept of the disease and emotional problems faced in the family and the group therapy is a very, very useful one. So in vitiligo management, that's very, very useful. And I have seen that this is one of the very important psychological intervention we can do, because these people, they're coming from different area. They can share the concept of the disease and emotional problems they have faced in their family and the society, and the various coping methods they have adopted in their life, and the treatment options and response to treatment, all they can discuss and they can get a good understanding. So here the problem shared is a problem halved. So you can see, but one of us should moderate the session, because the people all are vitiligo patients. So they are talking themselves, they are sharing their experience. So after this session, you can see wonderful change in their attitude and their thought process. So different types of people. One is a police officer. Then comes the family therapy. Family therapy is also very important, because the family involvement, that will help to share the psychological burden, and that will help to alleviate their anxiety regarding the disease. Especially in some families, they are thinking this is a contagious disease, they will not allow to touch the people, and help to adhere to the therapy, and they may give them a support network in the family, and here also they can share the problem in the family. That's very important. But the family management is a real difficult task, especially in children, in female children. This is very common nearing to the marriage age, where even if we are able to manage the child, it is very difficult to convince the parents, because the stress level is very, very high in the family. So family counseling is very important. Otherwise, they will transmit the stress to the patient. That is already mentioned by Dr. Sandil Kumar. So family management is very, very essential in vitiligo management. Then relaxation therapy, that's very useful in reducing the stress. So that will help in calming the mind and body. That will increase the self-esteem and normalization of sleep, decrease anxiety, and increase the parasympathetic activity and rapid clearance of the disease. Then another thing is hypnotherapy. That is also very useful. So medical hypnotherapy aims to decrease the sufferings, to promote healing, and help a person alter destructive behavior. So here what's happening is, during this hypnotic trance, an unhealthy response is converted into healthy response by positive suggestions or imageries. So here I'm giving a hypnotherapy to vitiligo patient. So we can change their mental picture by giving imageries, or we can give positive suggestion during hypnosis. The neurolinguistic programming is another psychological method we can utilize. So here there is one method that is called reframing. Here reframing means a technique to change the way you look at things in order to feel better about that situation. The kind of situation will be the same. For example, the vitiligo, the disease, sometimes we may not be able to cure, but the way we are seeing or we are interpreting the disease, we can interpret the same situation in a better way. So reframing does not change the external reality, but helps to view things in a different light and less stressfully. For example, this one I already mentioned. So here the white patch is there, and they are thinking this is very dangerous. But here we can reframe it by simply telling this is just the paint of the skin is lost, nothing else. So they will not have that emotional consequences. So that is very useful to use this type of techniques in vitiligo. Then breathing exercises are also very useful. Then another important thing is assertive training. So in these people, usually they will withdraw from the society, they will not have that assertiveness. So whenever they're exposing to such situations, they will have very difficulty in dealing with the people. So here assertiveness training is very important. So an assertive person is one who stands up for self and acts in his or her own best interest and express his feelings honestly, is in charge of self and in interpersonal relations. And the basic message sent from an assertive person is, I am okay and you are okay. By being assertive, we should always respect the thoughts, feelings, and beliefs of other people, and we should be able to say no in front of others, or we should be able to be very assertive. So the empowerment of the disease, empowered to live with the disease, that is very important, because many cases, even though there are many different types of treatment strategies, we know there are many number of cases which we are unable to cure. In such people, we should teach them to live with the disease. We should empower them to live with the disease. So teach the coping strategies, and coping means to invest one's own conscious effort to solve the personal and interpersonal problems in order to try to master, minimize, or tolerate stress and conflict. So this is one important area we should stress in the management. We should teach them how to live with the disease. So now the vitiligo day celebration, because the public awareness programs are very essential, because many of the stress factors are related to the society and family. So we should make them aware, the public, this is the real situation of the disease, because now the theme is awareness, support, and treatment, a united fight against vitiligo. So many psychiatric problems are related to socio-cultural factors and the stigma, the social discrimination, and the relationship issues in the society, in the family, in the between spouses. All these are related to the public awareness, and we should make aware the public regarding the real situation of the vitiligo cases. We know everybody wants to be fair, but if you are getting a white patch, it is very difficult to get married. But if you are getting a black spot, there is no problem. And a black spot on a white face is thought to be a beauty spot, and a white patch on a dark skin is thought to be an ugly patch. So we should try to convey the message that the white patch doesn't produce any problem. So we should try to change the attitude of the public. Then comes the pharmacotherapy. In minor psychological problems, only the psychotherapy is sufficient. But if there are major psychological problems like very severe depression, suicidal ideations, and very severe anxiety, such cases, simple psychotherapy alone will not be effective. So pharmacotherapy is also very useful. So various antidepressants like SSRIs, I am using this, especially escitalopram and fluoxetine, sertraline. These are very useful antidepressants that is highly useful in very severe depressive cases. Then other antidepressants, these are also very commonly used. Then bupropion. When tricyclic antidepressants, they have got so many side effect profile. So the SSRIs are the one which is highly useful with less side effects. Then mirtazapine, this is mainly an antidepressant where we can use in people with lack of sleep. So in insomnia people, this is highly useful. Then benzodiazepines used as anxiolytics. Alprazolam, clonazepam, that is one compound that is commonly used, and we should be aware that we should not give for a prolonged period more than 2 weeks, so that will produce dependence. So the non-benzodiazepine like buspirone, that is a very good molecule, but inferior to other benzodiazepines. There is no sedation, no impairment of sexual function, and no habituation potential. That is useful but less effective. So in conclusion, in case of minor psychiatric morbidity, psychotherapy alone is sufficient. But in case of major psychiatric morbidity, psychotherapy plus pharmacotherapy is essential. So the take-home message, skin is a major organ of emotional expression, and vitiligo is a typical example of mind-body connectivity. So mind and body has to be considered as single unit and has to be treated simultaneously. And referral to psychiatrist is often not acceptable to the patient. So basic level psychiatric knowledge is essential to the dermatologist. So thank you for the patient listening.
Jasmine, please unmute yourself.
Thank you, Dr. Abdul Latif, for your very informative and valuable speech. Actually, psychological intervention is a very important part in management of vitiligo patient. Now the question answer session and also the panel discussion. I request the participant to ask your question by writing it down on the chat box. There are already few questions, and Dr. Mahbub Shaheen has answered few of them. Is there any? There is a question. Is there any role of ibuprofen in progressive vitiligo? I'd like to ask this question to Dr. Mahbub Shaheen.
Okay, thank you, Dr. Jasmine Lina. Ibuprofen, as you know, it's an NSAID, so it's some sort of anti-inflammatory effects. But so far, I don't found any effective role of using this drug in the management of vitiligo. Especially, I don't have any experience using this drug.
Thank you, Dr. Mahbub.
Jasmine Lina.
Yes.
This ibuprofen sometimes used those patients receiving phototherapy, especially more than 1000 millijoule per centimeter. Those cannot tolerate. In that case, prior to phototherapy, this drug is used for photo adaptation. As far as you know, for photo adaptation before the patient receiving the phototherapy, especially in more than 1000 millijoule per centimeter. This, in that case, the ibuprofen for photo adaptation. Thank you.
Thank you, Dr. Tauhid. We have Professor Dr. M.A. Wahab sir with us. I would like to ask sir a question, sir. In case of diagnostic consideration, how frequently you found the association of vitiligo with the other autoimmune disease?
Thank you, Dr. Lina. First of all, I thanks organizer to arrange such a conference, virtual conference. I must thank the presenter, particularly Bangladeshi counterpart, Dr. Mahmood and Dr. Mahbub, for their brilliant presentation. And also thanks the Indian counterpart of Shadin Kumaran and the Dr. Latif for their brilliant presentation of the psychological aspect of vitiligo. Now the question asked by you, there are many associated disorders mainly communicable with the vitiligo, that is vitiligo associated disorder. If you think, first of all, it comes thyroid disorder, then diabetes, Addison disease, pernicious anemia, and besides this, there are a lot of diseases come into consideration with association, starting from atopic dermatitis, psoriasis, autoimmune connective tissue disease, depression and anxiety disease are already mentioned by the Indian counterpart, and the chronic urticaria, chronic insomnia, and many other things, deficiency disorder, many other things comes into consideration association with vitiligo. But mainly what we did in our private practice, thyroid related, that is thyroid panel, that is T3, T4, TSS, and the anti-thyroid peroxide antibody, anti-thyroglobulin antibody, anti-nuclear antibody. Beside this, some of the vitamins B12, ferritin, iron, to exclude SCTAs, Addison disease, SCTAs, and for exclusion of diabetes, we have to do many diabetes-related tests, that is fasting sugar, breakfast, and the HbA1c. And these are the common things usually we do in our private practice to exclude associated disorder. But if you think, one thing you must remember, if you think any associated disorder, if you treat the associated disorder, the
vitiligo must not cure, because you have to treat vitiligo at the same time. You have to treat the associated disorder like thyroid and pernicious anemia or Addison disease or the diabetes. Thank you, Dr.
Thank you, sir. There is a question from Torun Narag. He wanted to know that which screening tool do you recommend for evaluation of psychiatric comorbidities in vitiligo? I would like to go to Dr. Sendil Kumaran, sir, for answer this question. Sir, which screening tool do you recommend for evaluation of psychiatric comorbidities in vitiligo?
Comorbidity is the most
Could you please
specific.
specify? Yes.
Yeah, the most specific ones where the vitiligo is much better, as well as the VIS 22, vitiligo impact scale 22. These two are good to assessing the psychiatric comorbidities also.
Okay, sir. Thank you.
Yeah.
Dr. A.T.M. Asaduzzaman sir is also with us. So I would like to go to sir. Sir, please, in case of progressive vitiligo, which medical treatment do you prefer to stop the disease progression? Do you use a systemic steroid? If used, then in which dose and for how long?
Thank you very much for asking me to answer the question. Before going to answer my question, I like to thank our foreign delegates. They nicely and very elaborately learning us to manage the vitiligo patients. Because actually as a clinician, we are actually dealing with the pharmacotherapy of vitiligo or surgical therapy of vitiligo. We are actually we actually do not cover the psychological aspect of vitiligo patients properly. So this will be an insight to us for managing holistically the vitiligo patients. But in case of rapidly progressive vitiligo, actually on my part, I usually use systemic dexamethasone or betamethasone 0.1 milligram per kg for 2 consecutive days in a week for 3 months. This is for holding the progression of rapidly progressive vitiligo in case of non-segmental vitiligo cases. But actually, if we combine systemic steroid along with narrowband therapy, it will give more stability of disease progression. But this is not actually feasible on part that we cannot use these medications with narrowband therapy. And I think there are other options also, as minocycline is also mentioned. It is not available, but the impact of these drugs on progression of halting the disease process is not actually known to me. Thank you. Thank you for giving me opportunity to answer the question.
Thank you, sir. Now I would like to go to Dr. Smita Prabhu for my next question. That I wanted to know, how do you counsel your vitiligo patients routinely to empower them?
Thank you for the question.
Yes.
Yeah, regarding my vitiligo patients, I counsel them based on their age or the background they come from. So most likely, if there are children, I counsel their parents also. So my counseling method depends upon the level of understanding they have. First of all, I tell them it's just a disease of the skin. It is not skin deep. And then I try to find out whether they are highly anxious or whether they are depressed about the disease, whether they are finding any conflicts, or if there is any ostracization from society or friends. So after getting their background, I try to tell in simple terms what vitiligo is, that it is just a condition where there is a temporary arrest in the pigment producing cells. So don't worry, we'll try to treat and make you better. But if it doesn't happen, even otherwise, sometimes it can improve. I try not to give a negative aspect. And still, if I find they are overly anxious or they are very sad and depressed, I would not hesitate to refer them to clinical psychiatry or psychology. And plus, we do have some methods of relieving their stress here. As Dr. Latif elaborated in his talk, we also use certain simple methods like asking them to take deep breath when they feel very anxious about their condition, or to think about pleasant things. And I even show them pictures of celebrities in the laptop saying these people have overcome the condition, so you also can. And many of my patients are of marriageable age or youngsters who are just entering into relationships. Such people, I would like to counsel along with their partners. And many parents are worried that their children won't get married, or if they have vitiligo, their children won't get married. So in this case, we tell them it's not a contagious disease. Even though it is heredity, it's not likely that everyone will get it. I just tell them with example saying your child has an almost equal chance as any other child without parents with vitiligo to get the disease. So there are many methods of counseling and making them accept the condition, but it varies from person to person. It's not the same for all.
Thank you, Dr. Smita.
Thank you.
Now, Dr. Tawhidul Islam Imdad is with us as an expert panelist. I'd like to ask him that what is the role of sunscreen in vitiligo patients, and what is your advice regarding use of sunscreen agent?
Thank you, Dr. Lina. First of all, thank you, Association of Psychodermatology of India, as well as Association of Cutaneous Surgeons of Bangladesh for arranging on this vitiligo approach, how to approach the treatment of vitiligo on the occasion of the Vitiligo Day, World Vitiligo Day. First of all, I must thanks to Professor Abdul Latif and as well as Professor M. Sendelin Kumaran, as well as our Bangladeshi presenter, Dr. Mahbub Shaheen and Mahmoud Rahman. Vitiligo sunscreen is important because there is loss of pigmentation. So in that case, sunscreen is regularly used. We can divide in two groups. Those are receiving the phototherapy. They have more protection is needed. That is a broad spectrum sunscreen, as well as wearing the hat and other to cover the other parts of the body, because they are already receiving phototherapy. And those are not receiving the phototherapy, they also use to protect the skin for avoiding the sunburn, as well as to develop the skin cancer. In this case, they also use a broad spectrum sunscreen, and regularly when they go outside from the home, and regularly they use the sunscreen as a broad sunscreen. This is all the patient have to follow this rule.
Thank you, Dr. Imdad. Now, Dr. Rahmatullah Siddiqui, would you please share your experience with JAK inhibitor or tofacitinib in treating vitiligo patients? Dr. Rahmatullah Siddiqui. Okay.
Sorry, Dr. Jasmine, repeat please. Yes. I can't hear you.
I asked you that would you please share your experience with JAK inhibitor or tofacitinib in treating vitiligo patients?
Thank you, Dr. Lina. I have not a use experience with this medicine, but a little bit. Few cases I saw there is a very magic response with these drugs. First, before that, we have all the investigations, prerequisites investigation we have done, and after that, if patient is eligible for this drugs, we can advise these patients. But we have to wait to comments for a large scale patients dealings. I have not such experience, but it's really some patients we saw very nice. Nice and satisfactory improvement with this systemic new drug.
Dr. Jasmine Lina, may I add something?
Yes.
Thank you, Dr. Jasmine Lina. It's really very important questions as because I have mentioned in my presentation that JAK inhibitor, especially tofacitinib, is available in our country for last 2 to 3 years. And from the very beginning, I have started to use this drug, especially managing alopecia areata and vitiligo, where the involvement is more than 5% and disease is progressive. So in that case, I use this drug 5 to 11 milligram daily, and from 12 years and above the ages, particularly the young patients. As you know, most of the vitiligo patients are within the 30 years of age, same as in alopecia areata patients. And I have found is a very good safety profile and really is a very effective drug to arresting the disease process. But the important thing is maintenance treatment. That is the most important part of using this tofacitinib. And after using this tofacitinib, usually I don't prescribe steroids, oral steroids, and found I can actually avoid the side effects. As you know, long-term use of steroids are giving you a lot of side effects. So considering the side effects and safety and efficacy, tofacitinib is really very good drug of choice for the treatment of active disease.
Thank you, Dr. Mahbub. Here is a comment from Dr. Sendil Kumaran. He said that in present COVID pandemic, it's generally avoided because of its immunosuppressive effects.
We have actually published the role of immunosuppressives in the present vitiligo treatment. If anyone wants to read, it's a review article in a Pigment International Journal. With the as of now, the safest is 3 OMPs only because of the immunosuppressive, because of the present pandemic. Otherwise, I do not have anything regarding the effect of tofacitinib itself. Tofacitinib, it's a very good drug. It has shown very good improvement as far as topical as well as oral has been given, with either alone or with the presence of phototherapy. So only with the background of a pandemic, we do not know what is the total immunosuppressive effect. That is the only thing.
Thank you, sir. Here is a question from Tarun Narag. He wanted to know that what is your experience with minocycline in management of vitiligo? I think anyone can answer. If you have any experience with the minocycline in treating vitiligo, then you can answer this question.
Dr. Jasmine, just I have started to using this drug. As I have mentioned that the efficacy of this drug is study shows almost similar to oral mini-pulse therapy. So hopefully after a few months later, I can share my experiences about the efficacy and safety of this drug in the management of vitiligo. Thank you.
Thank you. We hope so. Here is another question: the role and effectiveness of laser therapy in progressive vitiligo. I want to ask to Dr. Hafi, Bishorul Hafi, would you please share your experience in laser therapy for treating progressive vitiligo? Dr. Hafi. I have another question to you, Dr. Bishorul Hafi, that how can we assess the psychological impact of vitiligo patients objectively in your experience? Can you hear me, Dr. Bishorul Hafi? You are muted. Please unmute yourself. Your network is...
Dr. Bishorul Hafi, would you please unmute yourself? Your microphone is muted.
His network is not working properly.
Some network issues with his. Hello, can you hear me?
Yes, yes, Bishorul.
I was not able to unmute myself because it was showing that host is not allowing. So for your first question, laser therapy,
patient.
Yeah, I don't have much experience. I think speakers will speak better on this regard. Hello.
Hello.
Can
Yes.
you hear me?
Yes. Not
Yeah.
properly.
So about your
Interrupted
second
voice,
question, I want to. Yeah. Now, can you hear me now? Sorry, I'm in a village,
we can
so
hear you,
network
but
is not that good here.
yes, yes. Your network is not
Yeah.
properly.
Yeah. So anyhow, I will try to convey what I want to say. Okay.
Okay, okay.
So first of all, I would like to congratulate the Bangladesh organizing committee to arrange this program and to cooperate. I mean, include us PDA once again in your program, because in a program by program, our academic relationship is getting stronger, and I think after some programs we will be like one. Okay, so about this objective assessment of psychiatric or psychological comorbidities in vitiligo, first of all, we have to think, why do we want to assess it objectively? In our day-to-day practice or our daily OPD routine, we don't want to assess it objectively. You just have to spend some time with the patient, make a report, so you will understand whether patient is having any psychological or psychiatric comorbidities when due to vitiligo. After talking to 2 to 5 minutes, I usually ask the patient one direct question. After making the report, I ask patient, I will ask like, you please tell me honestly, how do you feel when you see yourself in the mirror undressed? Okay, so if the patient is psychologically impacted with vitiligo, he or she will suddenly break down. I have seen in many patients in that kind of thing, because our patients may they might not want to give up because of this vitiligo, and they will put a brave face in front of world and in front of their colleagues and in front of their friends. But when they go back to their home and in their loneliness, and they will be all filled with their thoughts, and they will think about their present, their beautiful past, and their uncertain future. And many patients, they will keep on looking the photos of their the days before vitiligo. So if you go to the literature and read about the self-narration of vitiligo patients, they all says that the most difficult part will be like when they are alone, and when if they can see themselves in the mirror without any psychological impact, that means that they are okay. Sometimes the people surrounding them, they may trigger some hard feelings, but that is momentarily, that will go. But their thoughts, their intrapsychic mechanisms, if that is affected, they can't see themselves in the mirror with a calm mind. So the objective assessment actually comes if you are in a liaison clinic planning some studies regarding this. In our clinic, we actually use some of the questionnaires which Dr. Sendil Kumaran beautifully narrated. So we actually use, along with the JD7 and PHQ9, we use Dermatology Life Quality Index, DLQI. As Sendil Kumaran sir told, it is a 10-point questionnaire, and it's very easy to use. Sometimes in a busy OPD, we can't use it ourselves. I have one assistant who is a MSW, so she will fill up this for me. Then I use vitiligo quality of life assessment, VitiQual. Then if the patient is a pediatric child, then I use Children's Dermatology Life Quality Index, which again Sendil Kumaran sir beautifully described. Then most importantly, we have to see the impact on family also. For that, we can use self-related measurement scale or dermatitis family impact questionnaire or family dermatology life quality index questionnaire. Any of this you can use. So with this, you can measure objectively the psychological impact on the patient as well as on the caregivers. So, after regular assessment, you can understand that if your treatment is just causing repigmentation, or is it increasing their psychological, level also, that you can assess it. That is the most important part of objective assessment. That's all. Thank you.
Thank you, Dr. Bishul Hafi. Here is a question from Dr. Akram Hussain. Which percentage of vitiligo patient requires surgical procedure, and whom is that case, or vitiligo patient can be a case of surgical treatment now? I would like to ask this question to Dr. Mahbub Shaheen.
Okay, thank you, Dr. Akram Hussain. I have already mentioned in my lecture that at least 10% of total vitiligo patients who are actually presented as a case of segmental vitiligo, which is within a very short period of time, that is most of the case within a year of time, become stabilized. And as you know, stabilization, the stability of vitiligo is the prerequisite for surgical management. So at least 10% of all the vitiligo cases presented in our chamber is suitable for vitiligo surgery, and stability is the prerequisite.
Thank you, Dr. Mahbub Shaheen. Actually, there are so many things to know, but I think we are quite exhausted by this time. So I would like to go to our closing session. Actually, it was a very informative and lively discussion. In our closing session, I'd like to request Dr. Senthil Kumaran to give his some conclusive opinion about our today's webinar. Dr. Senthil Kumaran, sir.
Good evening again. It was a wonderful being as a part of this wonderful team. Thank you very much for the Bangladesh team. It's my first interaction with the Bangladesh team, to tell you the truth. I had met two people when they had come from Bangladesh to our Axicon in New Delhi. So, but somehow I didn't see them over here. But it was a wonderful discussion, and thank you even the PDI for giving me this opportunity to come in touch, and very good informative lectures, as well as it is good to see people are doing so much in Bangladesh also. And we are also open. You can take my email ID. I can provide if any sort of thing, discussion, case files or anything, any help which I can do from my part for the pigmentary community. That'll be fair. I'll be there to help you out. Thank you very much for giving me this opportunity. Lovely evening.
Thank you, sir, for joining with us. Now I'd like to request Dr. Abdul Latif sir to give his conclusive remarks.
So thank you for Bangladesh counterpart, because we are very happy to see you frequently. And as a whole, these 4 sessions, they were very interesting, very informative, very lucid. And the whole program was very nicely organized and very nicely conducted. And moreover, the interactive session, that also was very lively, and almost all area we have covered in this brief time span. So the Cutaneous Association, the Bangladesh Association, I appreciate for their enthusiasm in conducting these types of program to enrich the people, to enrich their knowledge in a holistic manner. And this is one area, especially the psychological aspect, that was a neglected area even in India. But now it is upcoming, and now the orientation and the people's awareness is increasing. I think the Bangladesh also, after the last meeting, the awareness is increasing. That's why we are again conducting this program. And a condition like vitiligo, that needs very high psychological intervention, because many of the cases we know that's not treatable. Even though there are surgical interventions, I have done almost 400 or 500 cases of vitiligo, the melanocyte transfer surgery, and I published articles also. But we know in spite of all these therapeutic options are there, there is a major chunk of people, especially the acral vitiligo, where the therapeutic response is very, very less. And that is very visible to the public also. So all type of psychological burden will be there. So we should be able to manage this area. And especially we, the dermatologists, should be equipped with that, because the referral to psychiatrist or psychologist is often it is not possible. So our treatment armamentarium, especially in the holistic approach, we should strengthen it. So our collaboration will help in future to enrich our knowledge, and we can give a very good service to the humanity. So that's how our collaboration is fruitful. So thank you once again for inviting and for this collaboration. And in future also, we can collaborate in almost all the areas. So we welcome to India and wish you a very good future in your association activities and personal life. Thank you. Thank you. Good night.
Thank you, sir, for your nice opinion and also for being with us. Now, I'd like to request Dr. Smita Prabhu from India to give her opinion.
Thank you.
Dr. Smita was our previous General Secretary of Psychodermatology Association of India. And she is from my place, also from Calicut district. So we are, and she was just my junior also in the study period.
Thank you, Dr. Latif, for the introduction. And thank you, Cutaneous Surgeons Association of Bangladesh. It was an honor to be here, and I thoroughly enjoyed the program. Very educative, very illuminative, and kudos to you all for conducting such a good program with a very good interaction. Thanks a lot, and hoping to be associated with you again.
Thank you, Dr. Smita, for joining with us. Now, Dr. Bisharul Hafi, or another guest, an expert panelist, would you please give your opinion?
I see, even now, some are asking questions in the chat box. That shows the enthusiasm of our participants. Okay, I don't mean to, continue this program, but, this audience is, very, very much interested to know new knowledge and new skills. That shows the, this peculiarity of this audience. And as an association, the PDI, Psychodermatology Association of India, will be always with you to arrange such more and more programs. So again, it was a pleasure to be with you all again. I think it's my third time. So thank you all. Thanks again. Good night.
Thank you. Now we have a very short certificate giving session. Actually, it's a little bit different initiative of our today's webinar. I think Dr. Mahmoodur Rahman will help us to conduct this session. First, I would like to request Professor Dr. Mohammad Shohidullah sir to give a certificate to our honorable speaker, Dr. Abdul Latif sir, and also our panelist, Dr. Bisharul Hafi.
Thank you, Dr. Lina. It is my great privilege to participate of giving a certificate to the honored and learned persons like Dr. Latif and Dr. Bisharul Hafi, as you have told. This is my second interaction with them, and I am waiting for the third, fourth, fifth, and so on interaction with them. And I also hope that I will meet physically with them, maybe in Bangladesh or in anywhere in the world. The honored person should be honored. That's my aim. And also, if I could do it directly, physically, that I would be more happy. But this time, it has been done virtually, but it has the same importance, or the more importance than the physical certificate giving ceremony. So I think Dr. Lina,
Yes, sir.
this is all about from my order.
Okay, so now I would like to request Professor Dr. M.A. Wahab, sir. Sir, are you with us?
And
Dr. M.A. Wahab, sir. Okay. Yes.
Lina, mouth shine can give. Mouth shine.
Or Asad, sir, ATM Asaduddin, sir. Okay, sir. Okay, Dr. Mahbub Shaheen.
Okay, thank you, Dr. Jasmine Lina. Again, I would like to thank Psychodermatology Association of India for giving us very good collaboration with the Association of Cutaneous Surgeons of Bangladesh for arranging an wonderful sessions, and hopefully in future we would like to arrange more and more common dermatological conditions where psychological aspect is closely related and carries much more value. So thank you again, sir, all the speakers, panelists and participants for participating these very important sessions. So thank you, everybody. Thank you. Thank
Dr.
you so
Mahbub
much.
Shaheen, I'm requesting you to hand over the certificate to our honorable speaker, another speaker, Professor Dr. Sendil Kumaran, sir, and also panelist Dr. Smita Prabhu.
Jasmine, Lina, কিভাবে দিব আমি আসলে আমার idea নাই. I don't have any idea.
Yes.
They will already get the,
It is.
They will already get.
It is in my hand.
Okay.
It is in my hand. I shall transfer. It is in my hand.
Professor Sendil Kumar, sir. So this certificate is to Professor Sendil Kumar, sir.
Thank you.
Sir,
Thank you.
we are grateful. We are grateful and very delighted to give you this certification. Thank you, sir. Thank you very much.
Thank you very much, Dr. Mahbub. I'd be actually very happy if you can share your 3 years experience with tofacitinib in our
Yes, sir.
journal.
Sir, can I share with you a little information?
Yeah,
My
yeah.
experience, what I've seen, that using this tofacitinib 5 to 11 milligram, I have found that there is no or little side effects. But when I using this drug is to more than 20 milligrams, that actually gives a lot of problems like infections and some other problems. But I found even in this COVID pandemic situations, using this drug instead of methotrexate or steroid, 5 to 11 milligrams. This is my experience that I can share with you.
Really,
So thank you, sir. Thank you very much.
You can write your experience and share it in our channel. We can put it across, because generally what happens, tofacitinib does not comes as a, it is actually recommended for something else. These are all other indications. So unless we are too very careful, no, if we end up with some sort of a complication and if the patient pulls you to the court or something like that, then we are caught up. So that's the reason why during these things, it is better to be in a safe hands rather than get our hands burnt. That was the only reason for me saying.
Thank you, sir. Thank you very much.
Thank you. And also Dr. Smita Prabhu is receiving her certificate. Actually, all of them are already got their certificate in their email, and it's just a formal arrangement. Now I request Professor Dr. Abdul Latif sir to give the certificate of the chairperson of our today's session, Dr. Mohammad Shahidullah sir. Dr. Abdul Latif sir will give his certificate to Dr. Shahidullah sir. And he also give his certificate to Dr. Mahmudur Rahman, one of our speakers.
So I'm showing the certificate in my mobile phone.
Okay, sir, thank you. And
I got the certificate, sir. Thank you, sir.
Yeah. So please accept it.
Thank you.
Dr. Abdul Latif sir also giving a certificate to Dr. Rahmatullah Siddiqui, another expert panelist. And our special guest, Dr. A.T.M. Asaduzzaman sir, is also receiving certificate from Dr. Abdul Latif sir.
So that's also with me
Mm.
in my.
Okay,
So it's very easy to give from India to Bangladesh in this
yes.
time.
And
True,
now
True,
I-
Dr. Latif, it's a new way of giving it, I think so.
Thank you, sir.
now I request Dr. Sendil Kumaran sir to give certificates to some of our panelists and speakers. I request him to give certificate to Professor Dr. M.A. Wahab sir, one of our senior teacher and expert panelists. Professor Dr. M.A. Wahab sir.
This is for you. This is for you. Congratulations, sir. It was a very good informative talk on panel. Thank you so much.
Okay, thank you. Please give Dr. Sendil Kumar sir, give a certificate to Dr. Mahbub Shahin sir, Dr. Mahbub Shahin, one of our speaker.
Sir, this is for you.
Okay, thank you, sir. Thank you very
It
much.
was a wonderful presentation. I really enjoyed it. Thank you so much.
Thank you very much, sir. Thank you.
To Dr. Tawhidul Islam Imdad, one of our panelists. He will also receive certificate from Dr. Sendil Kumaran.
Thank you, sir. Thank you, Dr. Sendil Kumaran, sir. Thank you for your receiving.
It was
from you.
wonderful. It was wonderful
you.
to visit you, sir. Thank you so much.
Thank
This
you,
is
sir.
meeting you live.
Thank you.
And also Sendil sir to our moderator, our today's Sendil sir, please give certificate to our moderator.
Moderator.
Yes, yes.
I had only 3 certificates to be given. Anyway, I would want. Yes, no problem. I would love to give the certificate to our moderator. Thank you. And one for Dr. Jasmine Lena also.
Thank you, sir. Thank
From
you.
me. Thank you.
And now I would like to request our chairperson, Professor Dr. Mohammad Shahidullah sir, to express his valuable remarks about the discussion and at the same time to conclude the session. Professor Dr. Shahidullah sir.
Okay, thank you, Dr. Jasmine Lina. So it is almost 11:30 at night, but how this more than 2 hours has passed, I don't know. But I was so much delighted with the discussion and presentation today. Today's subject was very interesting because at one time we are getting the most modern treatments of vitiligo, and at the same time today's subject was how to approach in the management of case of vitiligo. From the corner of psychodermatology, we have learned many things from our learned presenters like Professor Latif and Professor Sandeep Kumaran and Dr. Smita Prabha, and also from Dr. Bishul Hafi. Today is my first introduction to Dr. Sendil Kumaran, and I am really impressed with his presentation. Although most of the presentation was so fast that it went above my head. Sincerely, I am saying. But I really enjoyed, and that opened my knowledge or seeking the knowledge of vitiligo in the light of management, recent advanced managements as well as the management in the light of psychodermatology.
Thank you very much, sir. Thank you.
First of all, how to approach with this case of vitiligo, it is very important. We have learned many things of pharmacotherapies, say as for example antidepressant. But if we want to prescribe one antidepressant to a patient, I think today's patients are mostly literate. They go through the literature, they go through the nature of the drug. Then when they will find that doctor is giving some antidepressant, in most of the cases they will not allow, I am not depressed, so I will not take this drug. This drug is very sleepy. This sort of attitude they will show. This is why this today's webinar is useful. How to approach to a case of vitiligo from this psychodermatologic part. This first of all, we have learned from this today's discussion that we will have to prepare the patient. We will have to prepare the patient to have his own rational thinking, as Dr. Latif was telling repeatedly. We should abandon the irrational thinking and we will produce the attitude of the patient to go for rational thinking. If they can think in rational way, there is no chance of producing depression. This is very important. This is important to prevent the depressive thinkness. Yes, Dr. Latif, who is in your lab?
That's my granddaughter.
Granddaughter, okay. Thank you.
He's also hearing you speak.
So today, we have learned many things, and our participants, they also shown a lot of interest in this subject. I hope the psychological part of today's presentation in the management of vitiligo, that has created a lot of impression among the participants and also the panelists and also the speakers. So these interactive lectures are really useful for us and for everybody, I think. And with an approach to Professor Latif, yes, so we are ready to have cooperative managements or cooperative gestures to form this psychodermatologic subject upgraded in our country.
Thank you, thank you, thank you.
He has already mentioned that he is ready to help us, he is ready to improve our psychodermatological approaches. So thank you, Dr. Latif. And in future, I hope we'll continue this sort of attitude and we'll continue this sort of webinars. And as the Corona era is restricting the attitudes or restricting the our arrangements, I think after this Corona effects, we'll meet physically, we'll meet more arrangement like this physically in our country or India or anywhere else. We'll learn more. For the young doctors, I have a request that please, in the management of vitiligo, don't depend on the present pharmacological treatment. You must learn the psychodermatological part of management of vitiligo, because most cases are chronic cases. Most of the cases, they're suffering from some sort of anxiety disorders and depression. So these are the part of psychodermatologic part of this disease. I must thank the participants. I must thank the presenters for their nice and elaborate presentation, and also the panelists for their lively discussion. And I also thank the Uniderma for the technical support to make this webinar successful. Last of all, I invite my friends in India, please visit Bangladesh at any time. So we have an eagerness to see you physically, directly. So thank you very much for your patience participating in this webinar.
Your call will be
Thank you, sir.
Your call will be addressed, sir. Sure. If your invite will be addressed, sir. That is my part.
We'll try, inshallah.
Thank you, sir. Thank
you. After this COVID pandemic, we can meet.
Sure, sir. That's the thing.
Yeah.
Thank you,
Sandil also
for
I'm seeing for the first time. Sandil.
Thank you very much. I've heard about you because Tarun has heard about you.
Yeah, Tarun is my friend, and I'm seeing you for the first time.
Okay, Dr. Leslie Lena, please.
Okay, thank you, sir, for your conclusive speech.
Thank you very much.
Now, finally.
Okay. Yeah. Please.
Finally, I'd like to give thanks to Uniderma, and I request Mr. Anisur Rahman from Uniderma to propose his vote of thanks very shortly. Mr. Anisur Rahman, please. The Uniderma who has supported us from behind the screen to make this webinar successful.
Thank you, madam. Thank you very much. Honorable President and Secretary General of Association of Cutaneous Surgeons of Bangladesh and Psychodermatology Association of India, today's speakers, panel of experts, learned doctors, good evening. I'm Mohammad Anisur Rahman. I'm working as a marketing manager at Uniderma, and Bangladeshi doctors all know Uniderma. For Indian doctors, Uniderma is a concern of Unimed Union Pharmaceuticals Limited, which is a very big company in Bangladesh. And Uniderma is truly focused on dermatology. It is our great honor to participate in this scientific seminar webinar on vitiligo on occasion of World Vitiligo Day. On behalf of Uniderma and Unimed Unihealth Pharmaceuticals Limited, I'd like to thank you for choosing us as a scientific partner. I'd like to thank today's speaker, Dr. Mahmudur Rahman and Dr. Mahbub Shahin from Bangladesh, and Dr. Professor M. Sednil Kumaran and Dr. Abdul Latif from India. I'd like to thank Professor Dr. M. A. Wahab and Dr. Bisurul Hafi, Dr. Smita Prabhu, Dr. Tawhidul Islam Imdad, and Dr. Rahmatullah Siddiqui for enriching the program as panel of experts. And also special thanks to our special Dr. A.T.M. Asaduzzaman sir as a special guest. And I'd like to remind you that for the management of vitiligo, we have vitilimas, which is the preparation of tacrolimus. And we also have Soritar, which is a 2% preparation of coal tar preparation. And thank you for prescribing these products frequently. And again, thanks to all of you for making a great program. Wish you a good night and want to see you again in next program. Thank you, sir. Thank you very much. Thank you, madam.
Thank you, Mr. Anisur Rahman. Now we are at the end of the session. Finally, I would like to give thanks to all the speakers, expert panelists, and special guests for their very knowledgeable presentation and discussion, and also for giving their valuable time. And I extend my thanks and gratitude to all the participants of this webinar for their patience and valuable participation. Thank you, everybody. Thank you all.
Thank you, one and all. Good night. Good night. And wonderful moderation also. Wonderful time, ma'am.
Thank you, sir.
Yes.
Assalamu alaikum.
So we can meet, inshallah.
Thank you very much, sir. তাহলে বিদায় নিচ্ছি, স্যার।
Okay, thank you.
আমি ক্লোজ করে দিলাম, ম্যাডাম।
আচ্ছা।
থ্যাংক ইউ। আসসালামু আলাইকুম।